Hello, everyone. Welcome to Primetime Live with Next Level Prime. This series is meant to let listeners hear about all things Next Level Prime. I'm your host, Dr. Karen Rakers, Vice President of Next Level Prime, and I am a family medicine physician. I've been with Next Level for almost 10 years, and I'm thrilled to have been involved with our Next Level Prime program since it launched over 3 years ago. As a reminder for our listeners, Prime is an advanced primary care model. We contract with employers, which allows employees and dependents to have access to unlimited healthcare services at Next Level 7 days a week. We have a virtual care platform combined with a large network of physical locations in Houston, San Antonio, Austin, and Beaumont. And the care provided includes primary care, preventive care, chronic disease management, urgent care. We have health coaching and emotional wellness counseling as well. We also include a team of nurse care navigators to help patients with their healthcare journey and also managing any referrals that might be needed. We also include most commonly ordered labs and routine vaccinations, and all of this care is provided at no cost to the patient. So no copays and no deductibles and no surprise bills. We are really trying to break down the barriers to care, including cost and convenient access, while providing employers a cost-effective healthcare solution as well. Today, I have Greg Coldewey, a strategic consultant at Brown & Brown Insurance, on the show with me, and I'm thrilled to have him. He has been working with employers to find creative solutions to building their healthcare plans. And the focus of today's discussion is what hinders employers from making healthcare related changes. And thank you so much, Greg, for joining me. Welcome to the program. I'm going to just jump in by hopefully having you tell us a little bit about your role at Brown & Brown.
Yeah, well, good morning, Dr. Rakers. So it's different now than it was 5 years ago. So today I'm working on building very different types of health plans. 5 years ago, we did what traditionally everybody did. We had some self-funded business. We had a lot of fully insured business with carriers and networks. And I had a red pill moment that this isn't working. I just kept delivering rate increases year over year. And many times it exceeded those members' pay increases, their increased contribution. And I just got to the point where I thought, I can't do this anymore, and started looking for what are the problems and then are there solutions to those problems. And so that leads us to where we are today. And it's been a long journey, but we're figuring it out. And so what I do today, I kind of compare it to being an architect of a building. So I help design it, bring in the right vendors, and then I have an amazing team that makes it all work after that. But so the second thing that I think is the second most important part of my job is I can continually looking for ways for the members of our health plans to get access to care. And didn't realize that was such a problem, but it is a huge problem. And so continually looking for direct relationships with great providers that we can provide to these folks at a price they can afford or no cost, and they actually get preferred access and preferred timing. And so that's a big part of what I do, is look for those solutions to bring to our members.
It's remarkable that access is such a huge issue in the United States. Here we are, 2024. That seems like it shouldn't be a problem, but you're absolutely right. It's a huge problem.
Well, people think that their carrier insurance card provides access. It does not.
Yeah, that's right. Well, let's talk a little bit about the topic of the show today, and your opinion on what you think hinders employers from making health care related changes.
Yeah, that's a great question, and it's a pretty simple answer. There's really three things, I think. The first one is the biggest one, and is they don't know there's something else out there. The vast majority of employers we talk to, everything we're talking about is brand new information, that there's a different way to do it, that they don't understand the problems they understand their cost is too high. They understand the deductibles are too high. They understand all those things. They don't understand what's underlying that, what's creating those issues. And they don't know that there's another solution. And frankly, there's not very many advisors out there telling them that there's another solution. It's growing. It's a growing movement, as you know, but most of them just don't know. So because it's brand new, then there's the fear of the unknown. Will this actually work? They're scared of losing their logo on their ID card. They're fearful of disruption to their members. There's all these things. But once they really see kind of behind the curtain, most of them are willing to undergo those challenges to get to the solutions.
Yeah. I think, getting stuck in that rut of, the BUCAs and, the thing that they've done for the last 10, 20, 30, 40 years, with regards to their healthcare plan, it's challenging. It's a big step.
It is. And many of them haven't considered being self-insured before. And
right.
Self-insured is just the vehicle to get to the solutions. It's not necessarily the solution. It's the vehicle that gets you to the solutions, because the carriers aren't going to implement any of the things we may talk about today.
Sure. Okay. Well, we're talking about carriers. I mentioned BUCAs. So give us your thoughts on whether carriers are actually even aligned with trying to reduce healthcare costs and or claims.
Yeah, so
I think that's a big issue, right? That's what the employers are they're trying to figure out how to reduce their costs and still provide.
So that is a great question. That is one of those moments that our employers adopt, is when they learn that the carrier has exactly the opposite goals of theirs. They're completely unaligned with their interests. And so the reason it is twofold. One is that obviously the minimum loss ratio and the Affordable Care Act, which limited their profit, so to speak, to 15 or 20% of total revenue. So the only way to get more profit is more revenue. And the other one is, this is an important understanding, is that these carriers all report to Wall Street. Wall Street expects and demands increasing revenue. The only way they can do that is to increase cost to employers. So the carrier's revenue is the employer's cost. So their interests are completely misaligned with those of the employers. The other thing that's happening is the vertical integration. So when the carrier owns the PBM and the drugstore and the physician, and then they're negotiating with themselves, so to speak, for cost, there's really no incentive anywhere to control cost. All the incentives are aligned to increase costs. So there's no alignment with what the employers are wanting and what the carriers are trying to do.
That makes it pretty tough.
Does.
Yeah. So those are, I think you've hit on some of the big reasons why, cost of care is going up, but are there other things that you think are driving the cost of care up as well?
There are so many things. Sorry about that. But pharmacy is a huge one, as everybody knows, both from the cost of the meds from the manufacturer level to the pharmacy benefit managers, all of those things, that it's dramatically increasing cost. Hospital, as we know, are the fastest growing cost segment of our economy, and it's not even close. There's nothing even close to second place. And so part of that is that the carriers are negotiating for their network discounts. Well, they both have an interest in raising the costs. So that's exactly what happens. So hospital costs are huge problem. I think another problem, this one is more difficult to solve, and I'm getting into your area as a physician, but I think siloed medical care, where you have so many different specialists caring for one symptom, and you don't see very many of the physicians actually trying to get to the root cause of what's causing all these various symptoms. So if you have a diabetic patient, they may be seeing a cardiologist and endocrinologist and nephrologist, and they're all very focused on that. Ophthalmologist, they're very focused on that one symptom that the disease is presenting, but who's really managing and trying to solve the underlying problem? So I don't know how to solve that one, but I think it's a big problem. And I'll leave that to the physicians and the medical community to try to figure that one out. And this is one I've been thinking about a lot recently, which again, I don't have good solutions for, but we're doing so many things to control the unit cost of care, how much we pay for drugs, how much we pay for hospitals, how much we pay for surgeries, how much we're paying for primary care. We're doing all of these things, and yet costs actually do continue to go up. And the reason is there's just so many more sicker people. I think it's pretty common knowledge that we have an epidemic of obesity and diabetes.
Yeah.
And that is the problem that ultimately has to be solved, or these costs will continue to overwhelm employers regardless of what we do on the unit cost side. So there's a lot of issues to be solved. But
Yeah. Well, we'll get into some of what you talked about a little bit. We'll talk about maybe a little bit later, as far as like the siloed care and approaching the whole patient. I did want to kind of ask about free market healthcare. You talked about direct contracts and things like that. How do you think that all fits in with some of these solutions?
I think it is the most important thing that we're trying to do. And we're trying to connect patients with great providers and pull the insurance out of the middle of it.
Yeah.
So that takes many, many forms. And the more that we can implement in a given market, because it is kind of market specific as to what you can accomplish, but we have direct contracts with hospitals where our patients have no out-of-pocket cost at those facilities. That's good for the hospital because they're not chasing bad debt that they're never going to collect. And so it's good for everyone. We have bundled care solutions where virtually any surgical procedure can be provided in a bundled up price that is significantly less than you might otherwise pay through a network. Direct primary care, huge component of what we're trying to do, where we can try to solve some of the siloed issues that we discussed before, where you have a primary care physician that actually has the time to deal with the patient's root causes, help them on their healthcare journey, rather than a 5 or 7 minute visit to prescribe a med. So direct primary care is a really critical component of the free market healthcare solution.
It did not take... Oh, go ahead.
I mean, obviously PBMs are a big component too, because pharmacy's 30-40% of cost. And if we can address that by carving out some of the middleman costs at a traditional PBM, then that's a huge win. But a lot of different solutions, depends on the market and depends on the client's willingness to move forward with us.
Yeah. I was just going to mention, I've actually been practicing longer than I like to admit at this point, but it didn't take me long after, finishing up residency and getting out into practicing primary care myself. It did not take me long to recognize that I really felt like having the insurance as the middleman really felt like it was breaking down my patient-physician relationship with my patients. It was, navigating what we could and couldn't do versus what I felt was right. Big challenge. And so, yes, completely agree. And I'm thrilled to be moving toward working outside of insurance contracts, for sure.
Well, I think that this is going to continue to escalate as more and more primary care doctors are fed up with the situation that they're in, move into more direct primary care arrangements. That just exacerbates the problem on the insurance doctor side, and this will come to a head at some point. And because there's already a shortage of primary care doctors, and it's getting in some ways worse because the best ones, in my view, are moving into a direct primary care situation. So it's going to be interesting to see what happens there.
Well, those are the ones that thrive and want to have those longer conversations and dive in with their patients, instead of doing those real quick 5-minute visits with patients. So
correct.
That's a big difference. Yeah.
We're doing direct specialty care as well. And I think you're familiar with some of the things we're doing, but I mentioned that I think our plans and our employers are being overwhelmed with the cost of diabetes, not just from a financial standpoint, but from a business standpoint. And so we recognize that through the data we see in our health plans. And so we're now working with direct relationships within the endocrinology group that's doing amazing work to solve these problems for folks. And it's much like a direct primary care. It's based on time. The visits are an hour long. They're getting down to root causes of the disease. And what we're finding is that once people have a better understanding, you and I, or people in this world, we may think, well, everybody knows what causes, the kind of the cause of diabetes and what exacerbates the symptoms. I don't think that's true. And they don't know. And what's happening is they're getting educated at a level they can understand. And so suddenly they're more compliant with diet. They're more compliant with the meds, and they're getting better.
Yeah. Well, I know you are a big proponent of something that you call, or we refer to as, like a high performance health plan. Tell us a little bit about that.
A high performance health plan can be whatever you define it to be, right? But in my world, it includes some or all of the components that we've talked about. It's gonna be a self-funded plan because that's the only way to get to the solutions. It's going to include a really high quality, transparent PBM with some specialty med solutions. It's going to include some kind of direct primary care relationship. And it's going to include solutions for bundled surgeries and imaging and those sorts of things. So we have to get to lowest net cost. So beyond those things, or lowest unit cost, I'll say, beyond those things, how we deal with the rest varies depending on employer appetite, the market that we're in. It may include a network of some kind. It may not. We may use some form of reference-based pricing. We may not. So it's just what works in that market for that employer, but it's going to include good PBMs, direct primary care, bundled procedures, imaging, all those things. And then beyond that, we do what we can with the rest.
I'm curious with, some of the direct contracting and bundled payments, how are you controlling, or attempting at least to control, the quality component for the, what the patients have access to?
So that's a great question. And I've had those questions with some of the providers and got some great answers. So it's very difficult for me to say this surgeon is better than that surgeon, right? Who am I to make that decision? But here's what we have. We have anecdotal evidence. We've never had a complaint from a patient. They have great outcomes. They have great experiences. We've never had an issue with that. And, kind of, you may or may not be familiar with Surgical Center of Oklahoma, which is kind of the OG of this whole movement. And I was having a conversation with Dr. Keith Smith in his clinic one day. I said, "You've told me you have better outcomes. You told me you have better quality. How do I know?" Mm-hmm. And so he starts going down this list. And then one of the things he told me is, well, we only attract the best physicians. And one of the reasons we do that is because even though this bundled surgery is 60% less than the hospital, the actual surgeon is making more. Yeah. And that's the key person in that whole scenario. So he had about 6 different reasons, but the evidence is there that the quality that is being provided by him and others like him is superior.
Yeah, I mean, that's actually great to hear. I think it's been challenging. I feel like we're on the verge of getting better aggregated data on actual quality measures, because there's a lot of different things that play into it, right? So patient satisfaction is one of them, and outcomes, and all the things.
I think patient satisfaction is one thing. And that has as much to do with personality as the actual quality. So that's kind of a nebulous.
I agree.
Rating.
I agree. Yes. I think that's one thing we tend to look at now because we don't have a lot of other things to, in a real data forward way, look at. So.
Yeah. If we had really, really good quality measurement tools, then I think how we go about it would look differently, but I don't think we have that today.
Yep. Previous in our discussion, you mentioned some things about ACA and some other, regulatory things that, kind of influence what's happening. Talk about that a little bit for us, how some of these federal laws kind of influence what kind of decisions are made.
I think the biggest thing that's happened was that minimum loss ratio in the Affordable Care Act. All these laws are costly to comply with, and compliance cost continues to get bigger and bigger and bigger for our employers. But I don't think any of those things have had the impact of this minimum loss ratio, which just completely changed the game from the insurance company side, so that they no longer had any incentive whatsoever to control costs. Previously, they did, because if they made an underwriting profit, they could keep it, and they made money by, just like every other insurance company does, by controlling the claims cost. They made more money. That's not true anymore. And so it completely changed the incentive structure at the companies, and we can chart it, and we can see how costs begin to escalate dramatically in 2011 all the way to right now. So that's the biggest one. Compliance cost is getting bigger too. They continue to come out with things that our employers have to do, they have to report on, and it's annoying and expensive, but it just is part of the cost.
Yep. Well, we've talked about a lot of different, concepts and things. I guess bottom line, what strategies are you really utilizing to help your employers control some of these healthcare costs, the crazy rise that we've all been seeing?
We're building what we described as high performance health plans, and they all include those same components. They all include a great PBM with some kind of solution for expensive specialty medications, and those solutions can vary, but they'll include something like accessing patient assistance programs through the manufacturer, where we get those drugs for free. We could source them internationally from Canada, UK, New Zealand at half or less of the cost. So they're all going to include something like that. We think direct contracts are where we're moving in the future. We have some hospital contracts that are direct, and we have better results when we have that. And so that gets more difficult the bigger the hospital system. So I'm in discussions now with a pretty big one, and it's really complex to get that done. If you have a local community hospital in a small town, it's a lot easier to get that done. But you get into these big systems and it's difficult and complex, but we'll continue to work on it and see what we get done. Direct primary care, clearly, we've talked about it, direct specialty care. So we have the endocrinology group we're working with amazing results. We're continuing. I'm in discussions now with a major orthopedic group in our market that we're looking to provide continuum of orthopedic care, and they do it everything from, they own the entire continuum of care. So it's a great opportunity for us to have a direct relationship with that. So we continue to try to cut the insurance out and do direct arrangements with as many providers as we possibly can. And when we can't, we're going to probably do some form of reference-based pricing and deal with the consequences of that. But the more direct arrangements we can have, the more safe harbors the patients have, the less that becomes an issue. So.
Well, maybe specifically, more specifically related to Next Level Prime and what we are doing. How do you talk to employers? How do you get them to really think about adopting an advanced primary care type model?
Next Level Prime has made that discussion 1,000% easier, because while we can extol and we can talk about all the value of a direct primary care relationship, it's pretty expensive. It's worth it. There is an ROI, but it's a pretty heavy lift for an employer to look and just say, hey, I'm adding this to my fixed cost, and I'm hoping that it helps my costs down the road. That's a much more difficult discussion than Next Level Prime, because it makes sense to them, because they know they're paying a ton of urgent care claims today. They know they're paying for all kinds of costs related to that. They know they're paying for ER claims that shouldn't be. And so when you combine it all together with the primary care model you guys have and the urgent care and all the things you do in clinic, it makes it a really simple discussion. And we're getting no pushback from employers to adopt that model. So thanks for making it easy for us. But you're only in so many markets, right? We need help.
Yeah.
Yeah, it's a great model, and it's working for us in the markets where you are.
Excellent. Well, great to hear. Any final words of wisdom for us on how to break down the barriers, letting employers, change up their healthcare plans?
Well, you guys are doing a great job in terms of reaching out to employers directly. We have no issue with that. We think it enhanced. We feel like we're in a movement that we're all in it together. And so we love that. We love the passion of the leadership. We love everything about what we're doing with Next Level Prime. And the patients love it too. So
excellent.
We appreciate what you're doing.
Great. All right. Well, thanks everyone for joining again, our Primetime Live with Next Level Prime. I guess we'll end up seeing you again in a month or so.
All right. Thank you very much.
Okay. Bye-bye.